gastrointestinal disorders, stress reactivity, immunity, whole blood serotonin, and autism. Next slide. Do I control that, or do you? Oh, perfect. I asked for it. It's a joint site study. We are participating along with the university, the Vanderbilt University, and the Lurie Center at MGH for Children. And next slide. The rationale that we're looking at here is that there is, by some reports at least, a high prevalence of gastrointestinal disorders and autism. And regardless of whether your side is on how high this incidence of gastrointestinal disturbance is in autism, it is really quite clear that this is related to behavioral disturbances. So at the very least, it's causing discomfort for these individuals, and it is causing behavioral disturbances, which is often a problem in autism spectrum disorders. But it's also known that there's an increased stress response in autism spectrum disorders. And we've known for many years that stress reactivity relates to the development of gastrointestinal problems in the general population. A lot of people have been proposing that gastrointestinal disorders may relate to the cause of autism. Well, it's quite possible. We'd like to begin to explore the other route of this. But at first we want to see how there is a relationship between stress reactivity and gastrointestinal symptomatology. And norepinephrine actually may provide a mechanism for this because it plays a role in the role of stress in producing gastrointestinal symptomatology. Next slide. We did an initial study piloting to look at this question with 8 individuals with and without, 8 individuals each with and without gastrointestinal symptomatology, and verified the parent report responses with the Rome-3 assessment of pediatric gastrointestinal symptoms, which is being used more and more as an assessment in this kind of a setting. Next slide. We looked at galvanic skin response and electrocardiogram during rest in response to a couple of fairly established stimuli that elicit a stress response. And we found a main effect for greater GSR reactivity across the 3 conditions for the GI group relative to the no GI group. Next slide. We see it demonstrated in microsiemens, the mean skin conductance on the between the gastrointestinal group and the no GI group. And next slide. And we also see it for the vibrotactile condition, which interestingly was the most robust amongst those stimuli. So with this in mind, we wanted to do a larger study. Next slide, to look at how this interrelated. We looked at a couple of other aspects which are quite important, and we'll break into those as we go on. So as subjects enter at each site, the most recent parental questionnaire at the ATN survey regarding GI questions is assessed, and if there are GI problems, we look at the Rome-3 criteria to see if they meet the cutoff for GI issues, and if they have no GI problems, in order to make sure that we have a group difference, we look at the people that really don't have any significant issues, defined by less than half the minimum cutoff score, to be the no GI group. Next slide. Given what we got from the pilot study, we'll continue to look at GSR and EKG in response to a couple of stimuli and at rest. The tactile stimulation has definitely been shown to induce autonomic functioning with a collaborator of ours, and also cold pressor is a very, very well-established activator of the sympathetic nervous system. Next slide. Showing you a couple pictures to show you what things look like. Here's the overall setup where the patients come in to the room and do their testing for the 3 conditions. Next slide. Here's our equipment, the computer, and the Bobpack. Next slide. The Bobpack and the amplifier demonstrated here, and this is where the processing of all the GSR and heart rate data goes through, and each site has one of these in order to carry out the psychophys portion of this study. Next slide. Here's what a transducer looks like. Looks at skin conductance with the isotonic gel, being able to conduct from the skin to the leads and the EKG leads, just like in clinical medicine, just like you'd put them on, only with one difference, that we don't have as many of them because we're not trying to do a full EKG 12 lead. It's just a 3 setup. Next slide. We fill the transducer cups with gel and put them on the fingers after their hands are cleaned, as you can observe there. And then the next slide, you can see where the heart rate, as you can see, the conductance to the heart. Oh, that's a nice setup. I didn't realize we had the animation set up to see how the EKG reflects activity in the heart. But nonetheless, it's a very standard setup for psychophys measuring. Instead of the 12-lead EKG, you're just getting a positive, negative, and a ground lead, as demonstrated here. Next slide. And what we get is a psychophysical response. And as you can see, the GSR is a very steady wave that goes, wavers very slowly, and EKG is the typical EKG tracing that you would get. And the patients are instructed to rest quietly in the baseline condition while we assess this. Next slide. And the Beversdorf, they put their hand on a stimulator. It actually is pretty good at inducing autonomic response, 30 seconds per hand with a 3-minute baseline to give them a break to recover to baseline. That way we get some data for bilaterally. Next slide. And similarly for the cold pressor condition, after considerable discussion, we found some of our colleagues have had some success in doing psychophys studies with a rubber duck that they can grab a hold of, so that it's not just sticking your hand in the cold water, but you're grabbing the rubber duck and allowing them to maintain a similar amount of time, begin with a 3-minute break between. Next slide. In addition to this, we are looking at a couple of other aspects. We're looking at the atypical immune response in autism. Several immune markers have been found to be abnormal in autism, and I don't think it's any coincidence that some of these are stress-reactive immune markers, particularly IL-6 and TNF-alpha, and several of these are associated with gastrointestinal symptomatology. And so it would certainly seem reasonable to look at how these fit into context with stress reactivity and gastrointestinal symptomatology. Next slide. We will actually be doing these analyses at the University of Missouri site with our colleague Dr. Peterson, and being able to answer questions about how stress relates to immunity and through gastrointestinal symptomatology. Next slide. The serotonergic system is also intimately involved in the stress response. We have known for a long time, it's one of the earliest psychophys markers in autism, that whole blood serotonin is elevated in autism. There's a lot of debate about the specificity of this, and certainly this flies into our interest because it has been known that whole blood serotonin is also elevated after experimentally induced stress. The serotonin analysis will be done in collaboration with Dr. Veenstra Vanderwield's laboratory at Vanderbilt. And we're excited about this because our psychophys measures are really kind of getting at the adrenergic system. And this allows us to get a look at the serotonergic system to see if there's a serotonergic marker that interrelates with gastrointestinal symptomatology or the relationship between stress and gastrointestinal symptomatology. Next slide. We're also going to look to see if acute stress markers are, how reactive these individuals are through cortisol and amylase, collected through saliva. I'm sorry, I was just adding the comment of collecting through saliva. That's just a typical way of doing this. We have checked around about how to collect it, and there's a gentler Q-tip-like method that has been utilized at the University of Colorado that we've been implementing that seems to be working. Next slide. So our aims are first to examine the relationship between stress reactivity and symptomatology, looking at patients with ASD as well as gastrointestinal symptomatology, and predicting they will have a higher baseline and reactivity to GSR as well as heart rate variability as compared to patients without GI symptomatology, and this would be related to their adrenergic reactivity. Almost entered my power save here. Whew, saved it. We're also going to look at see how this relates to the immune reactivity observed in the same population. These immune markers are also known to be associated with stress and also known to be associated with gastrointestinal symptomatology. So systematic look at how all these factors interrelate, I think, will be very, very helpful for our understanding. And third, we're going to look at whole blood serotonin, predicting that since serotonin is also stress reactive, that it will be higher in the patients with gastrointestinal symptomatology. And with this, we can see, which ones of these drive the reaction. Next slide. In addition to this, we are in the process of recruiting 20 from each site from the ATN registry with GI and 20 without, for a total of 120 across the 3 sites. So 40 per site, half with, half without gastrointestinal symptomatology. We will confirm the gastrointestinal symptomatology as I described much earlier with the Rome-3. We're also going to be looking at this Spence Children's Anxiety Scale in order to begin to assess whether anxiety is a factor in this. And independent of independent trials of tactile cold pressure stimulation while collecting GSR, heart rate variability. We'll collect blood samples to look at the cytokines and whole blood serotonin, and a saliva sample to get the salivary cortisol and amylase. And for inflammation, we'll be looking at the markers that were described above. Next slide. All sites are now all trained up on the physiology protocol, the Psychophys protocol. The blood and endocrine marker collection protocols are set, so we are now rolling. We have completed the data entry form preparation with MS. So it's all ready for online data entry. All materials are set up, and 3-site IRB amendment approval is complete with all amendments having been done. It took a little bit of time going back and forth with the amendments and then going through MS and coming back to the amendments, but we've achieved all of this, and recruiting is definitely in process. Next slide. At about the time of that, the ATN meeting we had 2 months ago, we had completed all of that and started enrolling. We have 7 currently scheduled at MU. 40 are in the screening process, and many of whom I think will be able to participate, so we will be doing very, very well. Vanderbilt University has already finished 5 subjects and is screening another 40, and the Lurie Center has had 8 in screening, and 1 has already qualified as a part of the GI group and is scheduled to participate in the coming weeks. Next slide. We are currently calling ATN families, sending letters to ATN families, flyers in the clinical waiting room, and can recruit outside that the ATN is needed. This is approved through the IRB, and we will simply have to collect some of the ATN relevant data that is to be used in this study as we go along that process, which we have worked out with MS how to handle that entry for that. Next slide. And in Missouri, I'd like to throw a thumbs up out there to Jill Akers, who has actually had significant experience in recruiting even larger numbers of subjects for another study more recently, and I think an even shorter time frame, who is now our recruiting coordinator for this study, which we greatly appreciate her help, and that's how we have 40 people in screening right now. And this is really helping us move forward, and the other sites have very skilled folks along with them as well. Next. I'd like to give a thanks to the people involved. Brad Ferguson is taking a huge lead. Micah Mazurek is our she's actually our anxiety specialist. She's the one that if I had questions about the Spence anxiety assessment, I'd go to her. She has a lot of experience in looking at anxiety and GI issues, and I really appreciate her help. Jeremy Veenstra Vanderwill is a leader in the serotonergic system. And Evan Lee is actually has done rather significant work in the GI issues herself. So it's really quite a team. And Dr. Bowman, of course, with Tim Bowie, has done some incredible work and really kind of, I think, founded the whole GI issue with in the setting of autism. And her team, Christine Ferron and Carmen Koster, has actually done an incredible job along with Sarah Marler at Vanderbilt in helping us move forward. And speaking of moving forward, we have, I didn't put a slide on this, but we have submitted a grant already to Autism Speaks for the next phase of this work and putting a pre-proposal into the DoD. And I'd be glad to discuss that as we move forward with the Q&A session. And I apologize, but I do have a tendency for speaking very quickly and finishing talks on the early side, but hopefully that doesn't upset anybody's schedule today. This is open to questions.
David, thanks very much. I see that, Jill, you had either a question or a comment, and your comment seems to be 57, Jill Akers. I'll unmute you. Did you have a comment, Jill, you wanted to make according to what David's been presenting?
Jim, this is Brian. It doesn't look like Jill has audio capability. Her phone is in green. Yep.
Got it. Yep. Well, then we'll open it up for other people who want to raise questions at this point. I think we can unmute the group. Is that right, Alex and Brian?
We'll unmute everyone. Well, as they have questions.
Okay. So please ask questions if you have them. So one question I had, David, is sort of where does anxiety fit into all this? I mean, looking back to your original hypotheses and questions, I didn't quite see it there. So help us understand why.
Because I want to ask that question. It almost ends up being a fourth aim, but I think it's going to be a mediator of how things go, and so it's going to be included in the analysis in that manner. But we will look to see if it has its own effect independently. You're absolutely right; it could be acting on its own, but I think it certainly, what do we do for anxiety? We have additive treatments, we have serotonergic treatments, and so when we do our regression, we really want to see that's definitely going to be part of it, and we want to see how it factors in. And that kind of gets into where I would like to go with this. The next phase I see is do these factors predict who is going to respond to the standard gastrointestinal treatment? And by that, rather specifically, I mean, do the people who have greater psychophys reactivity or greater serotonergic reactivity, are they going to be the ones that fail when you give them their standard GI treatment for, say, gastritis, and are those people a subset for which anxiety treatment is going to be something important, and we may even be able to get an answer to that, to what type of treatment would be appropriate for them, based on whether that is driven more by the serotonergic abnormalities or the noradrenergic psychophys abnormalities. And I would think that the anxiety would go along with one or the other of those. And it'll be an important cofactor to keep track of as we move forward. It wasn't in the initial premise, but it really became obvious that we need to track it.
Okay, we'll see if we can get some other discussion about that as we go forward. Sue Sweeto, you had a question.
Yes, and mine is actually follow-up to yours, Jim. Thanks for recognizing me. I too was concerned about co-occurring anxiety, in large part because of our studies in children with anxiety disorders where we couldn't get a baseline that allowed us to ever compare change. So I just want to urge you to include some of those measures, maybe because of the time you didn't go into what kinds of evaluations you're planning to do for comorbid anxiety disorders, but that would be very helpful.
We're using the Spence Children's Anxiety Scale. It covers separation anxiety, social phobia, OCD, panic, agoraphobia, physical injury fears, and generalized anxiety. We think it's a pretty strong measure, but and it's been used in children with ASD and has demonstrated good internal consistency. But certainly expanding that search is if necessary. But we think that this gets at it, and we absolutely agree that it's important because stress reactivity might not be an issue because they're already peaked out.
Exactly, and I also think we had used some state trait anxiety measures, and you might want to look into that as well. So just have them rate their anxiety state at the beginning of the thing was quite helpful because it actually saved our study from oblivion, given that we could then document that the report.
It sounds like a straightforward thing to do too. In addition, state trait. Well, the good thing is we are also looking at our baseline measures. I mean, the whole blood serotonin is kind of a static measure collected at the same time. So that'll and as far as our psychophys measures, we have a baseline too that we're tracking, not just the reactivity.
Great.
So Sue and David, are you what are you thinking anxiety is here? Is it a state or a trait? How did it work out, Sue, in your studies?
Yeah, in our studies we found out it was both, and it's sort of fear, right, is thought to be the state, and anxiety is more the trait, but in actual fact, there's no nice, clean, dichotomous line between the two, so you have to kind of go hyperarousal, hyper activation states would then lend that person to be more anxious. And I think that in autism it's been interesting as people start trying to look at what the anxiety is, that as much as David has just clarified for us, a mixture of both. I just wanted to make sure he looks at both aspects of it.
Right, a good point. A couple interesting comments. I've done a number of studies, and every darn time I find the baseline heart rate, whenever I have them compared to controls, is always higher in autism. Every time the heart rate is higher. And so it speaks to to at least one or the other, depending on whether it's a reaction to the environment or whether their state is higher. The trait is higher, I'm sorry.
Would you expect your control and experimental groups to be different in the sense of their anxiety levels, i.e. the kids with and without GI disorders?
I think they probably will be higher, but I don't know which is the chicken and which is the egg in that situation.
Sure.
And that's the trick. This study won't get to that, but then follow-up studies would when you begin to look to see a treatment response issues and then, of course, ultimately treatment based upon that. And then you'd be able to get that question answered. There's always the question of, how accurate their introspection is, which always concerns me. But we can certainly, that's the only thing that left me with a little bit of caution on the anxiety scale. Having not measured anxiety, I would defer to others with a lot more, in that manner with autism, I will defer to others who have a lot more experience with that.
I don't want to, sorry, it's me again. I don't want to monopolize the conversation, but another piece that could be helpful is to actually measure your baseline at the end of the session. The heart rates tend to come down by then, and our patients have a lot more anticipatory anxiety because they do have the communication.
That makes a lot of sense.
Right, so if you, you still have to do it before to do your subtractions, but consider the baseline sort of after you've stressed them as much as you can and see if you can minimize the differences that way.
Yeah, right when you're saying, you're done.
Exactly. You're done, just one more little thing.
That makes a lot of sense.
Great. Other questions or comments for David? One of the things that they're doing that I know the reviewers found interesting was the use of the Rome 3 criteria to define GI disorders, and I know others on our team have used other strategies for definition of GI disorders. I don't know if anyone wants to comment on that. Sue Hyman, you've had a lot of thoughts about measurement of gastrointestinal functioning in a variety of ways. I think you're actually muted, though, and we can't unmute you. So
I could throw a comment on my end. We took our
Please.
lead from Pat Levitt's group looking at it. We really wanted to have something that covered a pretty broad range of gastrointestinal symptoms because this is somewhat exploratory. And then we have upper and both lower that are being looked at. So we could get a good smattering of what's going on from their gastrointestinal standpoint. It's a little more detailed than what's in the ATI registry. And actually they correlated quite well in our pilot study. We looked to see, I believe it was 100%, all of the ones that matched up with that qualified as Rome 3 also qualified as ATN registry with GI. And so it matched up pretty well. So it's basically being used as a categorizer, but we could certainly look at it with a regression as well.
And Susan Hyman says that yes, Rome is good, and the Bristol stool scale does not capture all symptoms.
Great.
You wanted to add
Thanks.
that?
I'm glad we're
I think so. One of the issues from the Rome 3 and from the GI symptom checklist that Tim Bowie and others developed early on is they're pretty good at observable GI problems like constipation. They're less good in a nonverbal kid with respect to pain, for example.
Yeah.
And I don't think any of us have been able to find the right way around the difficulty of really identifying GI problems adequately in kids who are nonverbal.
Fair enough. Fair enough. That's always a struggle.
Great.
We have
other questions? Go ahead.
Jim,
please.
did you handle? Peter Bell had a question that I wanted to ask for him.
I did not see it. That's great. Go ahead.
Awesome.
He says, do we have any comparison data on how children without ASD would respond to this study? In other words, would the ASD without GI disorder be similar to children without ASD?
That's really a good question. I don't completely know the answer looking at these kinds of measures. I mean, a lot of these immune markers and serotonin, whole blood serotonin things are being looked at in the setting of autism. Of course, we're really interested in what goes on in autism because this has such an impact on behaviors and on well-being. I mean, you feel awful, and a nonverbal person can't tell you why they feel so gosh darn awful. But that's actually a very legitimate question, and we talked about whether to add that, and it went beyond the scope of this level of the study because this study worked well within the ATN setting and recruiting, but we're going to have to build our networks with gastrointestinal disorder clinics across the sites in order to be able to ask that question to get we have a lot more better access to children with autism with GI symptoms than non-autistic individuals with gastrointestinal symptomatology at this point in time. But it really is a very legitimate question, maybe a very general question across gastrointestinal symptomatology that we will be able to help other kids in the future. And it's certainly not impossible that a whole range of other children perhaps with other disorders. I got to think, and as a quick side note, it's got to be awful stressful to have autism. And I could think of if I was dropped in some foreign country where I did not know the customs and couldn't figure them out, I'd be really, really stressed. And that's what they're contending with. And but I'm sure there are other situations where this is the case too. So in hindsight, I'm not surprised that there's a real stress issue in these individuals that may relate to gastrointestinal issues as well as immune issues. A long answer for a short question.
Well, but it also does raise the broad question of as we've done all of the studies that Susan Hyman has led in nutrition, we've really struggled to figure out how different kids with autism are from kids without autism in the sense of their nutritional data and so forth. And I think we don't unfortunately have a large amount of kids without autism easily available through the ATN mechanisms, but I think it's really great to be thinking about that. And as we broaden out some of these studies and look for funding from other sources, it would be, in many cases, helpful to have a control group without, or comparison group, excuse me, without autism.
Yeah, I agree, definitely.
So Eric Macklin, I don't know if you had any thoughts about, we had this conversation about the strategies about dealing with measures of anxiety. Have any suggestions for you, or do you have any suggestions for David and team about what this means analytically?
Can you rephrase for me, Jim? What's the
Sure. So,
question?
I mean, they have a pretty straightforward design. It's really looking at kids with and without GI disorders, gathering a variety of stress responsivity and serum data to really compare those two groups. That's a pretty straightforward analytic scheme. They're now saying, well, shucks, it might be that anxiety is a mediator here. Is that what you said, really, David? I think it might be a mediator.
That's what I'm thinking, although I don't, we're going to analyze it that way, but if it certainly comes out to be independent of the others in regression, we will pay attention to that.
So they sort of, I think, initially said they would look at kids with and without anxiety, or, whether you're going to use a continuous or a dichotomous scale, I'm not sure. And you have several subscales in the anxiety scale, and you could compare that with, again, your stress responsivity and your biologic measures, your serum measures. But if it's really a mediator, that calls for a somewhat different analytic scheme. That's really what I was asking Eric, if you could help me that through.
Right. So, I mean, there's the most complete model is having anxiety in both as a main effect and as an interaction with your GI status. If that interaction is different than 0, then that would suggest that anxiety is not just a mediator, but it operates independently depending on what the biology of the individual is.
Great.
If the GI, when you include it just as a main effect, and if the GI association disappears, then that would suggest that that the anxiety is mediating whatever features the GI is identifying. But yeah, some simple extensions of this multiple regression model that they're proposing, I think, would accommodate that easily.
With help and guidance that you have provided us already.
Great.
Sure.
So David, where does this go from here? Let's say you find some relationships here. Where are you going to take this next?
The next thing I'd really like to do is to look at, cone in on the patients with the gastrointestinal symptomatology, and look at whether or not the individuals with the greatest either stress reactivity on the psychophys measures or the serotonergic markers are also the ones that fail to respond to our standard treatments. And that could be really, really, really important. It may suggest that there's a subset of these individuals that really you need to do something different with. And those questions would actually help guide you as to whether it's an adrenergic or a serotonergic aspect that you need to be targeting. And so this may be, my hope is that this will begin to guide us to individualized treatment response, treatment plans for individuals based upon what all seems to be contributing or appears to be contributing to the gastrointestinal symptomatology. That's kind of the next, that's the next step, I think.
So pushing a tiny bit further in that, so let's say you find serotonergic effects, and these are kids who don't respond to typical therapies for GI pain, constipation. What are you going to recommend? I mean, I realize you're not going to recommend anything, but what are the candidates for treatment?
I think a good, if it's serotonin that seems to be atypical in these individuals, the first thing you'd want to look at is treating the serotonergic system. I mean, because it may be showing a reaction to something atypical in the serotonergic system, maybe an SSRI. It sounds kind of counterintuitive bringing it up, but maybe it's reacting to something that's going on. So you'd at least think that there's something abnormal with their serotonergic system, so serotonin might be the first approach for these individuals, a serotonergic treatment like an SSRI or an SNRI, to see if that helps with the anxiety measurement, with treating the symptom, the stress reactivity symptomatology that's contributing to this. And you'd also want to pay very close attention to those anxiety measures alongside. That seems the next logical step.
Great. So are there other questions people would like to raise with David about his team's work? It's a good team you've put together there. Any questions for
I'm
David?
grateful for them.
Okay, well, if not, I think we want to thank you very much for you and your team's hard work on this. Glad you're, let's see, we have one question, one other stress-related question.
Yeah.
Many children with autism seem to have dilated pupils, indicating some kind of stress-related response. Would this be another avenue for measuring level of stress that's occurring or seeing if it varies depending on the presence of GI symptoms or not?
It's a great idea. Absolutely. I think there is ongoing work at our site with a team that I interact with closely. It's looking at the pupillary dilation system as another marker of parasympathetic activity in these individuals. And as we move forward, I absolutely think that's a fantastic marker to see if these individuals, to target in these individuals. Absolutely.
Great, thank you. That came from Peter Bell. Okay, great. Well, I want to thank you very much. I think this is a really interesting project and really moving us along some really interesting new areas. So thanks for doing it to your team, and thanks for you all for listening in today. I think you know how to reach David.
And thanks to the ATN for the support.
You're welcome, the ARP too. And we're delighted that you have it, and we're looking forward to the results. Great.
You take care.
You too. Take care, all.
See you.